Thank you, everyone. I think it's wonderful to see such a great turnout for the very famous Dr. Justin Cross, who needs no introduction. He's been leading the teaching for many, many years here too, and I think that's one of the reasons why we've had such a great turnout. So he's going to talk to us today about some pediatric imaging. He's going to talk specifically about cerebral venous sinus thrombosis. So with that, no further ado, I'll pass you over to Dr. Cross.
Lovely. Thanks, Ferdia. Okay, I'm going to sit down here, which is what I've been instructed to do by Ellis from the IT department, because this is all being recorded, it seems, for YouTube and Twitter. And we've got a packed audience here in the Berridge room with at least 2 professors, so I'm a little bit intimidated, but I'll do my best to educate you on this topic of venous sinus thrombosis in infants and children. When Fiona asked me to do a forum, it sort of appealed to me to do something that related to emergency imaging. So I was sort of wondering whether I should go very broad and sort of cover all of pediatric emergency neuroimaging, or very narrow. And I've decided to go very narrow, you'll be pleased to hear. So I'm just limiting myself to this rather niche topic. Okay, let me see if I can get the next slide here. I'm failing at the first hurdle here.
The arrow will check you.
There we go. Okay, so just to set some objectives from the talk this evening, I'm aiming to go through the clinical and imaging features of cerebral venous sinus thrombosis. We'll talk a bit about the risk factors and treatment of venous sinus thrombosis, but that will be kind of at the end of the talk. So we're going to focus mainly on the imaging features, and I suppose really the incentive or the prompt for giving this talk were 2 cases that we saw over the summer with in neonates, actually, infants with venous sinus thrombosis. So I'll start off just showing you these 2 cases. So the first case was a 12-year-old, I think he was a little boy. He'd had a normal delivery and had gone home. And then in the following week or so, at about 10 days of age, he developed a temperature, and then he stopped feeding and had a decrease in conscious level, which I think happened fairly gradually over a day or 2. So he came to the emergency department, and he had some imaging. So this was the CT scan that was done when he was seen in the emergency department. So I'm showing you here on the left, in the left panel, an unenhanced CT image through the brain. And I'm not sure if my arrow will work here, but you can see, hope you can see some areas of high density in both thalami, these sort of crescentic areas, or almost sort of rugby ball shaped oval areas of high density. There's also some high density in the lateral ventricles. So that this looks like acute hemorrhage, which has spread into the ventricles. You'll also see there's some high density in the midline here, along the course of the straight sinus, and in the sagittal sinus here posterior also looks very high density. And then on the right-hand panel, I've changed the window settings, and this is a image post intravenous contrast medium. He was only a neonate, so he had about, I think, 8 or 9 mils of omnipaque, and these were the images that we obtained. So you can see the blood on this image is displayed as lower density than on the left-hand panel, which is a little bit confusing, but the contrast enhancing vessels are shown as higher density. So you can see these structures here are enhancing veins. So the internal cerebral veins here have enhanced, but this area that was high density on the unenhanced CT hasn't enhanced further. It's a different density to the vessels that are still patent. And the sagittal sinus here, you can see most of it is showing this sort of intermediate gray, which is we're interpreting as blood product, acute thrombosed vein, thrombosed blood. And there's a little channel of a pacifying sagittal sinus adjacent to it. So we interpreted this as straight sinus thrombosis with some sagittal sinus thrombosis and bithalamic hemorrhage. So he was admitted, obviously, and then I think a day or so later, he had an MRI. And here I'm showing the T1 weighted image. Probably could have made that a little bit bigger for you, but you can see, I hope, on the sagittal T1, some high intensity here along the tent. So this is within the straight sinus and extending into the vein of Galen here. And you can also see some high intensity in the sagittal sinus. This black signal here, that's probably flowing blood in the sagittal sinus. And this is a T2 weighted image taken at the same time, showing the edema. The blood, acute blood doesn't show up as well on T2. But some of this low intensity is probably representing the recent blood. And this that we know from the CT is kind of thrombosed straight sinus, and vein of Galen is showing us low signal. So that's quite confusing on T2 because it looks similar to flow void from flowing blood. So he had these two examinations. I think he was managed on the PICU for a few days. He wasn't given any specific treatment. He didn't receive any anticoagulation. He was rehydrated. I think he was thought to have an infection. He had some antibiotic treatment, and he went home a couple of weeks later in condition not too bad. You know, he's able to do what babies normally do. He's eating and crying and everything else. So he had a reasonable outcome, although with that degree of injury, the long-term prognosis is, I think, rather guarded. And then the other case that came was quite similar. This child was a little bit older. Again, it had a normal delivery and presented in quite a similar way with a change in behavior, becoming a bit more drowsy. I think he had a seizure or maybe several seizures at home, and had a decrease in conscious level. And this is the imaging that I'll show here. So this is the initial MRI that was done at another hospital, but you can see good quality images here. This is a sagittal T2 weighted image, and this is an axial swan, axial susceptibility weighted image. And this was interpreted as a normal MR, not unreasonably. But can anybody in the room here, I think we've got at least two professors here, anybody spot anything abnormal or anybody suspicious of anything on the images? Okay, thanks, Surin. So yeah, he has got rather a prominent CSF space here. Yeah, okay, thanks, Reem. So on this image, he's got quite a chunky looking vein here. It's low signal on susceptibility weighted imaging. So flowing blood is low signal on on SWI or SWAN, but this vessel looks quite enlarged, and it's got, you might be a little bit suspicious that the signal looks slightly kind of heterogeneous. I don't know if I can persuade you of that. And here the sagittal sinus, again, has got an odd appearance. It looks bigger than it should be. It usually has a kind of triangular shape, and this looks a bit kind of lobulated. And then when you look on the sagittal, you can argue that this straight sinus, again, is a little bit enlarged, although it's low signal on T2, which we would associate with flowing blood. But you can see there is a kind of a caliber change here, which is a little bit odd, that there's the internal cerebral veins are sort of normal and narrow, and then it becomes a bit more bulbous here. But I think, yeah, it's not unreasonable that those signs were overlooked. He came back, I think this is about 10 days later, also at the local hospital, excuse me. So I'm showing some different sequences here. So this is T1. Again, it's fairly unremarkable appearance. The brain parenchyma looks normal. In the transverse sinus on this side, you can see a little area of high signal. So typically on T1 and T2, the sinuses should show low signal from flowing blood, but that's not always the case. If the flow is rather slow or within the plane of the slice, they don't always show up as low signal. But you can see in this case, the left transverse sinus looks low signal. This is more ISO intense, but you can see that would be easy to overlook. And on the sagittal sinus, you can see that the sinus is ISO intense to brain, which again is not definitely abnormal, but could be abnormal. Okay, let me just go on to the next slide. So I think actually all those 4 images were done on the same examination, and then this is a week later. He had a CT scan and a CT venogram when he was in hospital having these seizures and generally not very well. This is the unenhanced CT. So again, like the first case, you can see high density here in the straight sinus. The thalami look normal on this occasion. Excuse me. And then when we gave contrast medium and did a CT venogram, you can see this sign here, a low density structure within the sagittal sinus. So this is what we sometimes refer to as the empty delta sign. And you can see, or may be able to see, it's not shown very well, these areas of abnormal density in the white matter. These are areas of hemorrhage, which aren't showing very well because of the window setting. This is an MR done at the same time as the CT. And you can see those areas of hemorrhage in the right cerebral hemisphere. So there's some low intensity, likely to be deoxyhemoglobin with some edema around it. And on the midline sagittal T2, you can see some abnormal intensity in the sagittal sinus. So this should be black on T2 if there's flowing blood. And the straight sinus is probably also abnormal. It's not as black as it should be. It's a bit heterogeneous and a bit enlarged. But I suppose, just to contrast those cases, you can see that sometimes the signs are fairly obvious, and other times these findings are quite subtle. It's useful to do an MRV. I'm sorry, that's not projecting very well, but this obviously is a flow sensitive sequence. So I suppose this is useful for what you can't see really. So this should show the sagittal sinus in the midline going around the top of the cerebral hemispheres, and you should see a straight sinus and maybe some internal cerebral veins. But here you can see arteries coming up from the neck, So, I think one of these is the jugular vein as well, so that there are two carotids and at least one vertebral artery. But intracranially, you can't see much of the venous system until you get to this point. I think that's one of the sigmoid sinuses, and maybe some attenuated flow in one of the transverse sinuses. But this is showing extensive venous sinus thrombosis. And on a follow-up CT, you remember the initial imaging, the brain was virtually normal. He's ended up with a big hemorrhage, venous hemorrhage. And I think, unfortunately, this child got very high intracranial pressure and didn't survive. So two different outcomes and different imaging patterns. Okay, so I wanted just to look at those imaging features in a little bit more detail, just to help us sort of recognize this pathology, which is rare, but obviously it's an important diagnosis to make. So we're going to look initially a little bit of detail at the anatomy of the dural venous sinuses, and then we'll look at some of the imaging features. So I would say the main features to look for on CT are a dense sinus. So particularly the sagittal sinus is often the easiest one to identify. But you can look at the sagittal sinus, the transverse sinuses, the straight sinus, as we saw in those cases, and cortical veins as well. You may see a, I think it's sometimes called a string sign. You can sometimes see a dense vein on the surface of the brain. Then after you've given contrast medium on CT or MR, you might see this empty delta, which is contrast around a clot. So that's usually best seen in the sagittal sinus. You get some clues on the signal intensity on T1 and TT, although, as we've seen, that can be misleading. So clotted blood can mimic flowing blood on sort of static MR images. And then usually we use MRV as the sort of primary way of diagnosing venous sinus thrombosis, although we do also use CT venography as well. Okay, so if we just start by looking a bit at the anatomy. Now, I think this is the venous phase of an angiogram, which I did probably about 25 years ago. And it's not in a child, but it happened to show the anatomy quite well, in that you can see the sagittal sinus here, pacified by contrast. You can see anteriorly, it's a bit thinner. So often the anterior third of the superior sagittal sinus is a little bit hyperplastic or thinned. And then this is more normal caliber, more uniform caliber. And the sagittal sinus runs back to this point that we call the torcular, and then it divides into the transverse sinus. You can see it on this image, which I think is a fairly straight lateral projection. The two transverse sinuses taking a slightly different course around the posterior fossa, which allows you to see them separately. And this is the sigmoid sinus draining into the jugular vein. On this image, you can't see the straight sinus very well, or the internal cerebral veins. So the sagittal sinus and the transverse sinuses and the sigmoid sinuses, this we refer to as the superficial venous system. And this receives, the sagittal sinus and the transverse sinuses receive these superficial cortical veins, which drain the brain parenchyma, and I suppose particularly the cortex and the underlying white matter. And then the straight sinus and the internal cerebral veins And the other tributaries, like the basal vein of Rosenthal, these constitute the deep venous system. And they drain, I suppose, as the name suggests, that the deep gray matter, so basal ganglia, thalami, and some of the deep white matter. So as we've seen, I think in those cases that I showed, it gives a different pattern of the venous infarction and venous hemorrhage, whether it's superficial or deep venous thrombosis. So this is a cartoon kind of showing the same anatomy, but it shows the straight sinus here more clearly. This is labeled as the vein of Galen and the internal cerebral vein, which I suppose makes this the inferior sagittal sinus, which often you don't see very clearly. It's often quite a small structure on MRV and contrast venography. But yeah, we'll come back to this image again, but you can see this paper here comes from Toronto. It's quite old now, but they have quite a detailed and comprehensive registry for pediatric stroke, and they collected, I think, about 160 dural sinus thrombosis events in Canada over about, I think, a 15-year period. So it's not a common event, but they looked at the different characteristics of the children. But you can see here, just as a rough guide, about 55% of the cases were superior sagittal sinus thrombosis. This is in children from 0 up to 16 years, and about 34% were straight sinus. So the superior sagittal sinus thrombosis is more common, and the deep venous thrombosis slightly less common. Well, like about half as common, 24% versus 55%. And they said the proportion of deep versus superficial venous thrombosis didn't really vary with age. Although in my experience that the deep vein thrombosis do seem to be more common in the younger children, but that wasn't borne out by their study. Okay, so that gives you an idea of the anatomy and distribution of where the thrombus is likely to occur. So just having or reviewing some of the signs. So we've obviously seen this image before, but this is just showing the dense venous sinuses. So this is the appearance we're looking for, very high density on CT in the straight sinus and the sagittal sinus. And then, as we saw a few minutes ago, when you give contrast, you sort of almost invert the image so that where the thrombus is lower density, and the contrast should opacify around the lower density thrombus. This is another, yes, that's the same image. I don't know why I've put that up again, but this is another case showing an empty delta. So here the sagittal sinus should opacify as a triangle of contrast, whereas it's just a very thin line around the thrombus, which you can see in this case is more or less the same density as the brain, which is a bit confusing. Okay, so that's the dense sinus and the empty delta. And then when we look at the signal intensity of the sinus, so we said that normally the sagittal sinus should be low signal on T2 if it's got flowing blood in it. And if it's thrombosed, you expect to see some higher signal within it. So you can see here the sagittal sinus with high intensity on the T2. But as we said, that fairly acute blood products, a deoxyhemoglobin, which starts to develop probably at about 24 hours after the blood clots, is also shown as low signal on T2. So if you see that in a vessel, that will then mimic flowing blood. But yes, on this sagittal, you can see the high signal, sorry, on the T2, where we should see low signal in the sagittal sinus. This was also abnormal straight sinus, as we've already shown, but it's got a mixture of high and low signal in it. Okay, and then on T1, this is an image that I've taken from the internet here, from this paper. I don't know if I've referenced that correctly, but it seemed to be from something called Cases Journal in 2009. It's quite a nice example of a very high signal sagittal sinus. So that's met hemoglobin in the sagittal sinus. So that usually would take 2 or 3 days to develop. So you may not see that if you do the MR very early, but that's pretty characteristic of thrombosis. Obviously, if you've got subdural hemorrhage adjacent to the sinus, that can also mimic a sinus thrombosis, but that's when you look at the anatomy carefully, obviously it's not going to conform exactly to the sinus. And then on the axial T2, as we saw in the previous case, the sinus is high signal on the T2 weighted image. And then just to rehearse the MRV, so this is quite an old style MRV, but similar to that case that I showed on the sagittal image, there's no filling of the sagittal sinus, which you'd expect to see on MRV, and on the axial acquisition or this axial MIP, you can see flow signal in the lateral sinuses, bit asymmetric. It's hard to know if that's related to slow flow, and some of this could be an artifactual flow gap, or there could be some thrombus extending into that transverse sinus. Okay, so that's just a quick run through the signal intensity of thrombus on MR and the density on CT. So we're moving topic now onto some of the variants of anatomy. So I'm just going to talk about these two entities, arachnoid granulations, which can mimic thrombus, and the occipital sinus, which is a sinus that is kind of a normal variant that runs between the torcular and the jugular foramen, and you see that more commonly in children than you do in adults. So just to talk a bit about arachnoid granulations, which I think we're all familiar with. So this is taken from the medical students' dissection manual. As a cartoon showing the layers of the meninges. So the purple line here is the pia mater. So that follows the surface of the brain, sends into the convolutions of the cortex. The pink line here is the arachnoid mater, and so the arachnoid is said to be like a sort of spider web. It's got these little kind of adhesions, very fine membranous structures within it. And where the subarachnoid space sort of meets the venous sinuses, there are these outpouchings of arachnoid, and we believe that CSF is reabsorbed into the venous blood through these arachnoid granulations. And then the yellow line obviously is the dura mater, which splits here to accommodate the venous sinus. So I guess this is probably the sagittal sinus here. So when we look at that on imaging, on T2 weighted imaging, they're often quite high signal structures. You can see on the right here, sort of following or along the course of the transverse sinus, these high signal structures. So it's not too confusing on there, I suppose. But on the contrast enhanced imaging, they can mimic a non-occlusive thrombus. They can be a tiny structure like that, or a bigger structure, filling defect, shown on the right-hand image. I've lost my mouse, but you can see a little oval filling defect within the sinus, which is a normal arachnoid granulation and not a thrombus. And I'm duplicating my images again, but on MRV, I think this is taken from the same patient. You'll see a flow gap, may see a flow gap at the site of an arachnoid granulation because the vein is narrowed by the arachnoid granulation, and there's a difference in flow as a result, which causes this signal loss. Again, that can be confusing on MRV. So that's just to show you an arachnoid granulation. And then I wanted just to mention this entity, the occipital sinus. So yeah, this was quite an interesting paper. Again, it's quite an old one, but they reviewed MR venography in a number of children looking for sort of variants in anatomy, and they pointed out this structure. So actually, this is one of our venograms, MR venograms, that shows this paired vein, two veins running from the proximal transverse sinus on one side down to the jugular bulb. This is the normal transverse sinus on one side, and that's the opposite transverse sinus. In this paper, they had this case where there's a sort of variant of anatomy with a very high torcular. So this is one of the transverse sinuses, sort of drooping down, and then the other one is over here. So it's quite a strange arrangement of veins that this child has. But you can see at the bottom, there are these two occipital sinuses that run from the transverse sinus to the jugular vein. And they've shown it here on the axial maximum intensity projection running from this, well, it's really one of the transverse sinuses over to the jugular bulb on each side. And then they looked at the instance of these, well, of the occurrence of this occipital sinus. And I think it's present in about 10 to 20% of neonates, and then it drops down by the time you get to 5 or 6 years of age. It's more like 3 or 4%, and it's in adults it's quite rare to see this structure. And they sort of postulated it's to do with lying down and that sort of altered pressure in the jugular vein that kind of keeps these more primitive occipital sinuses open. But I guess it's important to be aware of this structure because you can have thrombus within this occipital sinus, which may obviously cause symptoms and may look strange on imaging. Okay. So then I wanted just to have a look at some of the imaging artifacts that we see that can be confusing on MRV. So just looking at some of the MR artifacts, so really to do with flow gaps that can be misinterpreted as thrombus, and then on CT, this phenomenon of fetal hemoglobin, which can be problematic when you're looking at neonatal CTs on neonates because their blood is naturally higher density than you see in older children and adults. Okay, so these images are also filtered from a paper here, again from Toronto, but this is showing MRV, and it looks as though there's occlusion or absent flow in the distal sagittal sinus and proximal transverse sinuses. But when they did a CT venogram on the same child within a day or two, you can see actually that part of the transverse sinus that looked occluded was actually patent on CT venogram. And this is a technical artifact from MR. The way this MRV was obtained was using coronal slices to try and maximize the flow in the transverse sinuses. So the flow on MR will be maximal when it's at 90 degrees to the slice of acquisition. So it's detecting blood flowing into the slice from above and below. So if you reach a segment where the blood flow is within the plane of the slice, then you tend to lose signal. So that's the problem with MRV. When you reconstruct the images, the MIP reconstruction also can create artificial flow gaps. So it's good to look at the source slices as well as the maximum intensity reconstructions. Okay, that's MR, and then this was CT. I couldn't actually find a good case of a normal sort of dense sinus, and this you can see is also not a child, but it's just showing how the sagittal sinus, it can be higher density than the surrounding parenchyma. Usually in an adult, you can compare the density with the arteries. So if they're similar density, that suggests that it's the blood that's slightly either hemoconcentrated or it's got an abnormal constituent like a fetal hemoglobin. In neonates and the younger kids, it can be a bit harder because the arteries are often quite small. You may not get a good view of the arteries, but yeah, you need to be careful not to overinterpret a dense sinus in a young child. I suppose if there's clinical suspicion, you'd have to do a contrast enhanced CT or an MR. Okay. We're sort of getting through the slides now. So I was just going to talk a little bit about risk factors for venous sinus thrombosis. And again, I found it quite interesting that there's a little bit of variation with age, but actually the same conditions do sort of extend across the age groups. So I guess the commonest underlying causes do relate to abnormalities of clotting and underlying infection. So the clotting abnormalities are really the same that you see elsewhere in the body. Protein C and protein S abnormalities and genetic mutations in factor V Leiden, lupus anticoagulant, that sort of thing. You see really across the age spectrum. In neonates, for some reason, it's much harder to assess the coagulation of the infant. So they can't do the usual prothrombin time and the other tests of clotting function. So it can be harder to nail down a clotting abnormality in a neonate or infant. Infection is another important cause of that. Can either be infection in the middle ear and mastoid that directly affects the adjacent transverse sinus, or it can be a systemic infection which leads to dehydration and makes the patient sort of pro-coagulant, puts them in a pro-coagulant state. Another slightly unusual cause is iron deficiency anemia. We see this sometimes in infants. It's usually slightly older infants, so maybe a few months old, not the neonatal group. You sometimes see it in children that are exclusively breastfed, because that doesn't have breast milk doesn't have a very high iron content. And I think it's not clear why iron deficiency anemia causes venous thrombosis, but it may be that the iron deficiency state stimulates the bone marrow, creates sort of cellular messengers that affect the endothelium, and I suppose I sort of view it that the body may be thinking that it's bleeding to death, you know, causing the iron deficiency, and it's trying to plug a hole somewhere that's making it produce too many clotting factors. But that's probably not an accurate scientific explanation. So I don't fully understand that, but that's not an uncommon association in children, particularly babies with sagittal sinus or venous sinus thrombosis. And then there are other systemic inflammatory conditions like lupus, systemic lupus erythematosus that we talked about with the lupus anticoagulant, anti-cardiolipin antibodies, so that the autoimmune conditions that generate those antibodies are associated with venous thrombosis. And this is usually older children and adults. There's definite association between inflammatory bowel disease and venous sinus thrombosis. Not sure how we're doing for time, 30, but I'm coming to the end now. I just wanted to say a little bit about the clinical features, really to say that they're quite non-specific, and they do vary a bit with age, but not much. In obviously young infants, you won't get the history of headache, but you can see these are fairly non-specific neurological symptoms: seizures, headache. There may be signs of raised intracranial pressure, such as papilledema, and clinical features that the headache is worse when they lie down. Focal neurology is quite unusual. This is just showing the age distribution, so you probably can't read this, but you can see in their registry that the majority of children seem to be much commoner in infants compared to older children, which was interesting to me, but I was quite surprised about that. And we've looked a bit about the distribution. So we said that it's more common to have superficial involvement than deep involvement. But you can see from the numbers here that it does also overlap. So you may have both deep and superficial involvement. And at the cortical veins, isolated cortical vein thrombosis in children was unusual, around about 6%. Okay. And then just to say a word on the treatment. So again, this is quite interesting, because you can see this is the overall, these are the overall numbers for children between birth and 16 years old. So only half of them actually received heparin or other antithrombotic agent. So particularly in infants, the clinicians are often very unclear whether they should anticoagulate young children, particularly if they're big venous hemorrhages, and particularly in infants where it's quite difficult to measure the clotting function of the child. So a lot of the infants don't get any heparin at all. So that probably accounts for that figure, that a lot of the neonates probably weren't given any specific treatment. And that's talking about heparin, so fairly sort of benign systemic treatment. In terms of catheter-directed thrombolysis and thrombectomy, in this study, I think only 1 out of the 160 children had catheter intervention. So that the evidence for catheter retrieval of clot, I think, is sort of thin at best. And that's usually used as a second-line treatment. But we have had cases here that have done very well with catheter treatment that weren't responding to heparin or other systemic treatment. And then you can see some other rather non-specific treatments, antibiotics, because I suppose infection or it can be either associated with infection or mimic an infection, anticonvulsants because seizures are not uncommon, and steroids, I suppose, if there's a worry about raised pressure. Okay, so that really brings me to the end of the talk. So I hope that we've covered some of the clinical features. I suppose really to say that the neurological features are quite non-specific, which makes the diagnosis difficult for the clinicians to make, particularly in young children. We've looked at these imaging features. So I suppose the things to remember on CT are the dense sinus and the empty delta sign. And then on MRI, to look for the signal intensity on the static images on T1 and T2, but beware of over and under interpreting that. And we've shown some of the findings on MRV, which again, it may not be that easy to interpret because you're really looking for structures that aren't present on the MRV rather than abnormal structures. So you have to know what a normal MRV looks like to see what's missing. And then we finished just by discussing a bit about the risk factors and talking about the treatment. Thanks very much.